Good afternoon and welcome to another episode of Community Relations Corner, where we discuss issues of concern to New York's Jewish community and our friends and partners all over the city and metropolitan area. I'm your host, Michael Miller, the Executive Vice President and CEO of the Jewish Community Relations Council of New York, or the JCRC. On each episode of Community Relations Corner, we're joined by guests representing the political, religious, economic, and diverse community leadership in New York, many of whom I've had the pleasure and honor of getting to know during the course of my tenure at JCRC-NY. Together, we'll discuss current events impacting the New York Jewish community and its neighbors, as well as the state of our city, the state of our state, the state of the nation, the state of the world. This episode is sponsored by the Free Synagogue of Flushing, serving the Reformed Jewish community in Queens, New York for over a century. Visit freesynagogueflushing.org for information about their Shabbat and holiday services, weekly Sunday school, and the beautiful spaces available for public rental. Once again, we thank our sponsor, and please do visit freesynagogueflushing.org. And now it's my pleasure. I'm very excited to welcome as our guest for today's episode someone who's been on probably more Zooms than he has fingers and toes, and probably members of his family as well during this epidemic, this pandemic. And that's Dr. Aaron Glatt, who is the chairman of the Department of Medicine, the chief of Infectious Diseases, and hospital epidemiologist at Mount Sinai, South Nassau, as well as the associate rabbi of the Young Israel of Woodmere. Please, Rabbi Glatt, so wonderful to have you here on Community Relations Corner. So to begin, please tell us a little bit about yourself, your medical practice, and your role at the hospital.
Thank you very much for having me. I think it's a very important opportunity to teach people about COVID-19, what we can do to all stay safe and get our country back to normal. So it's a pleasure and an honor to be here talking with you today. So I'm the chairman of the Department of Medicine at Mount Sinai, South Nassau, part of the Mount Sinai health system in New York City and in the greater area. It's a wonderful system, and I'm honored to be part of that system. And I'm honored to be specifically at Mount Sinai, South Nassau, which is one of the premier tertiary care hospitals on Long Island. And my responsibilities include all of the issues related to patients coming into the hospital in the Department of Medicine, as well as my responsibilities as the hospital's epidemiologist and chief of infectious diseases, and other roles at the hospital to make sure that the patients coming to our hospital are getting the best care possible, the safest care possible, and to keep both our staff safe, as well as the visitors and the patients coming to our hospital, in a nutshell.
Right, and you also have rabbinical ordination, and we're graduates of the same institution.
Yes, we are, and I'm very proud of that.
Yes, so Dr. Glatt has rabbinical ordination from Yeshiva University, from Rabbi Isaac Elkanan Theological Seminary, and as I said before, he serves as the Associate Rabbi Young Israel Woodmere, where the now Rabbi Emeritus, I guess his title is Rabbi Billet, Rabbi Heshi Billet, who was a classmate of mine. And I mentioned...
Just correct one thing. I learned at the Rabbi Isaac Elkanan Theological Seminary for many years, but my slicha is actually from the Mochon LaTorah V'Horoya, or Rom Tzvi Vosner Shlita. So I just,
okay.
That something incorrect was said.
Okay, thank you for that correction. And I also discovered, I mentioned to Dr. Glatt before we went on air, that there's a whole movement to study all of the entire Talmud, and Dr. Glatt gives a online class in Talmud, 1 page a day, front and back, 1 page a day, which takes more than 7 years to go through. He's now in his 5th cycle of studying and learning the Talmud. So that's an incredible achievement. And I don't know where he finds time to do that. And we're so happy that he found time to spend just a couple of minutes with us. So let's first start with COVID-19 itself. What is this virus and how does it affect the body?
So it's important for people to understand that we are familiar with coronaviruses for many, many years. Many of the typical cold viruses are coronaviruses. But this is one of three novel coronaviruses. And that's what makes it especially important. It doesn't act and function like the typical cold coronaviruses that have been around and are relatively unimportant from causing clinical illness. This illness, unfortunately, we've all seen, has caused a tremendous worldwide pandemic, resulting in millions of lives being either unfortunately tragically killed or severely impacted, long-term complications. And it's devastated society, devastated our social and religious customs, devastated businesses financially, devastated families for personal and other reasons. And it has been undoubtedly the single most important medical illness that we've had to encounter in the hospital in my career.
And again, what happens when coronavirus enters into your body? What does it impact on?
So the coronavirus, this novel coronavirus, COVID-19, has the ability to impact almost every single part of the body. It classically can cause no symptoms whatsoever to the full gamut of symptoms in almost every organ system in the body, ultimately, unfortunately, leading to death. So in many people, and in fact, the majority of people, they don't really get very serious illness from it. And that's very reassuring. However, in a very significant minority of people, there are very serious complications of this illness. And it can, as I mentioned, unfortunately, lead to long-term complications, acute, severe, short-term illness, and unfortunately can lead to requiring to be hospitalized, requiring to be in the intensive care unit, unfortunately sometimes requiring what we call ventilatory support. You need to be intubated, put on a ventilator, and it can tragically be a cause of death. And people with certain risk factors, including older age, including underlying medical problems, are more prone to having more serious complications from this illness.
And so what have you seen in your hospital, Mount Sinai, South Nassau, in terms of numbers lately as compared to at the start of the pandemic?
So people need to realize that different parts of the country, different parts of the world have been hit at different times, but everybody's getting hit again right now. The early part of this pandemic in the United States, New York was one of the epicenters, and we were starting to see cases back already in February. We weren't able to identify them clearly as such because testing was not available. And certainly once testing became more available and we were able to not only say clinically somebody had this, but by able to prove it. So we quickly saw very, very high numbers, and the spread of this epidemic in the New York area was horrific, with very, very high numbers, especially unfortunately in all communities, but in our community, in the Jewish community, we saw tremendous numbers of illness and hospitalizations and unfortunately death. And in March and April and May, right around Purim and Pesach time, so we were seeing in the hospital crushing numbers in all the hospitals in New York City and the greater general New York City metropolitan area, Long Island, New Jersey, Westchester, the whole general greater metropolitan area. So we were seeing incidences of disease that were crippling and overwhelming the hospital system. We stopped all elective surgeries. We stopped doing anything that pretty much was not an emergency coming into the hospital. And most of what was in the hospital was COVID. At our highest peak day, we had over 400 COVID patients in our hospital. And we had an additional 100 plus patients besides that. And this was well more than our normal capacity. And we put up tents to take care of patients. We commandeered conference rooms and turned them into patient care areas. And every single nook and cranny in the hospital was utilized to care for patients. And the hospital staff really were heroes. Sometimes we use heroes in a very loose sense. A person can hit a baseball very far, so he's a hero. He doesn't strike out at the bottom of the ninth, he's a hero. Soldiers are heroes. People working in the hospital are heroes. Policemen, firemen, those are heroes. That's how we define heroes. We can even extend that to saying other occupations. And I would just stress that the importance of recognizing how the hospital staff worked to their own personal lives being put at risk, and with sometimes lack of appropriate personal protective equipment that wasn't in abundance, so that we never ran out in very difficult, trying circumstances. They did a phenomenal job and are still doing every day a phenomenal job. And looking at the numbers, after we reached that peak of 400, we over time went down. And we were discharging patients that previously weren't able to be discharged and unfortunately passed away. And our ability to care for these patients improved every day in the pandemic, and to the point where we would actually, for one 15-minute period of time in the summer, had 0 COVID patients in the hospital.
Right.
15 minutes. And then unfortunately a patient was admitted. But we were running a census in the summer of between 1 in 3, 1 in 4 patients at any given time. And unfortunately, several months ago, we started seeing an increase, a slow but very, very steady increase. And to the point that we're now over 100 patients again in the hospital with COVID. And again, I'm giving you my personal hospital statistics, but these are the exact same in all the other hospitals in the general area. Everybody is seeing a surge again right now. We are very concerned that it's going to get worse. And we're very concerned that the resources that we have will hopefully be adequate. And we're constantly preparing and doing everything that we possibly can. Engineering staff are building new units, changing airflows, refiguring everything to make sure that we have enough of supplies, enough rooms, enough everything, personal protective equipment, to allow our staff to feel comfortable taking care of all the patients that, unfortunately, God forbid, we may see.
We see across the country that there are ICU units that are overwhelmed. Are we beyond that from where we were in March and April at a different stage today? But you're saying that it could get worse. Are New York City or New York area hospitals prepared for what might be inevitable in terms of the spike?
So I think the hospitals, again, have done a phenomenal job preparing. And when you think about it, we've also been asked now to vaccinate, which is on top of the surge that we're seeing. We're devoting tremendous amount of resources, and we're trying to work really 24/7 around the clock to make sure that we give every single dose that we get vaccination to every single patient that we're allowed to as soon as we possibly can. And we have retired nurses coming in. We have volunteers coming in. We have staff giving of their time. We have staff working overtime. And they deserve such tremendous credit. I couldn't be prouder of the staff at Mount Sinai South Nassau, but in general, the healthcare system has been stretched and stretched, but it hasn't broken.
Let's talk about vaccines. First, that appears as the Manishtana question is, why is this virus different than other viruses? So that's question number one. But question number two is, how does this vaccine differ from vaccines, let's say, for the flu?
So I think it's very important to realize that the types of vaccines that we have will differ for the type of illness that you're dealing with. We have illnesses that we've been unsuccessful in making vaccines against, and other illnesses we've been extremely successful. We've eradicated, the only disease God has ever allowed us to eradicate has been smallpox because of vaccination. We've come pretty close, and we'll hopefully get there with polio. We've done a wonderful job with measles. We're putting a lot of things at risk, however, when we're not vaccinating right now children. And across the world, some of our initiatives against polio and measles, the big concern is that they'll fall apart to a small extent, maybe even to a larger than small extent, because of the COVID crisis. But COVID is unique in many ways in that we have developed a vaccine against it in unbelievably record time. And we've used new technologies, albeit they've been technologies that we've been exploring since SARS-1. The first novel COVID coronavirus was identified in 2002 in the world, especially hard-hitting Toronto, but in different parts of the world. And we have already almost 20 years of experience dealing with novel coronaviruses. God was very kind to us to give us a prequel with what we now call SARS-CoV-2, with really the SARS-1 back in 2002. So we have built upon that information of almost 20 years to allow us to develop these vaccines, which are so essential. If you would develop a vaccine against the cold, we'd love to do that. But if we don't, it's not the end of the world. Flu is a very important illness. Influenza is a very important illness, a big killer as well. And that's why it's so important that people take their influenza vaccination. But in relative terms, a vaccine against COVID-19 will save many, many more lives. And the two vaccines that we currently have available in the United States through the FDA's emergency use authorization, what we call an EUA, are brought about, people should understand that without any skipping of any of the safety steps, we've been able to bring them to fruition so fast because of a number of reasons, which it's probably too technical to go into right now. But people should realize that no safety steps were skipped. We didn't jump and say, well, we're just going to forget about that because we're in such a crushing need. But all the phase 1 trials, the preclinical studies were done, phase 2 trials, the phase 3 trials, and they've been phenomenally successful, better than anybody could have expected or predicted. And we have 2 wonderful vaccines now in our armamentarium, and we're giving them out. There have been probably over 15 million doses given worldwide already. And we're hopeful that we'll get everybody vaccinated maybe by the summer. Certainly we want to get as many people as possible. There are so few people that shouldn't get this vaccine. It's really almost like a handful of people that shouldn't be getting this vaccine. Almost all people in the United States. Right now we don't have the data on children under 16, but we will have that. And until I can say that for certainty, I won't. But anybody above the age of 16, and certainly above the age of 18, should be vaccinated as soon as they can, unless they have one of the very rare conditions, very, very rare conditions, that they can't get this vaccine easily. Even then, they still may be able to get it. But right now, everybody should get this vaccine that could. It's a very safe and a highly effective vaccine.
But this is a relatively new type of vaccine. This is not like with influenza, where you get injected with, I think, a weakened virus.
Well, influenza is actually a dead virus. We give you a dead virus. It's not a weakened. There are vaccines, as you said, that are weakened viruses. We call it an attenuated virus. But with influenza, you never get live virus. With the 2 vaccines that are available for COVID, it's what's called messenger RNA. Now, messenger RNA is not DNA. It's not even regular RNA. It won't turn your body into something else. It will not change your genetic structure in any way, shape, or form. It is basically email. I like to think of messenger RNA, remember the M for email, that your body is basically being delivered through this vaccine, a message, this packet, this email, to send to the factories that produce antibodies in your body to please produce this antibody. And that message goes to your cells in your body that produce antibodies, and it makes an antibody against the spike protein. The spike protein is a 3-dimensional structure on the surface of these viruses. It's a microscopic structure. You can't see it. And if you were to be exposed to COVID-19 and you had antibodies against it, your body would say, that's a foreign invader. I know how to fight it, and it will go and fight it. God created an unbelievably beautiful immune system. What this messenger RNA does is it revs up the immune system before you actually go to battle. So when you go to battle, you're actually fully equipped to handle the enemy, the COVID-19. And therefore, these messenger RNA vaccines are just phenomenally good. And they're very, very safe. We've given 15 million doses of this now. We have no surprise, unidentified problems that have occurred. There are no deaths due to that vaccine. We have good, hard data on the allergic reactions that happen. There have been only 29 reported allergic reactions of significance, no deaths. As far as I know, only 4, possibly 1 or 2 more patients have been even hospitalized. They've all done well, and they've all been treated. That's a phenomenally safe vaccine. This doesn't cross the placenta. mRNA doesn't cross the placenta. A pregnant woman can get this. That's not only Aaron Glatt saying that, that's the American Society of Reproductive Medicine. That's the American College of Obstetrics and Gynecology. The CDC says it's perfectly fine to give this to a pregnant woman. There is no contraindication for a pregnant woman getting this, especially if she's on the front lines, if she's a nurse, if she's a respiratory therapist, doctor. They should be getting this vaccine. They're much, much, much more at risk of dying from COVID. Getting COVID in pregnancy is a serious concern. So the vaccine absolutely should be taken, in my opinion, and the opinion of all the experts that I just mentioned, even in pregnancy. There's nothing to suggest it causes infertility, despite what you read on the internet. That's garbage. It's just not true. And in fact, we have 44,000 women in the United States who were pregnant and had COVID. So we have a great deal of experience with this antibody, and it doesn't do anything specific that we've identified. So it should be given to women who are potentially thinking of getting pregnant, might someday want to get pregnant, and it should be given to women who are nursing. There are no contraindications in any of those categories for women getting these. In fact, there are tremendous problems with getting COVID in any of those categories that are real unfortunately fatal potential complications. To make the theoretical risk that you're going to get a 1 in a X number, 100,000 rare complications, which we haven't even seen yet, that will be a reason not to get the vaccine. There just is no reason not to get the vaccine.
There's another rumor circulating around that taking the vaccine actually weakens your immune system and could make you more susceptible to infection.
So that's silly. It's ridiculous. It's just not true. Just because somebody says something, there needs to be some evidence for it.
Correct.
Even a theory behind it, but there is no theory behind it. And I don't understand. I just don't understand the resistance to taking vaccinations in this country. And in every aspect of medicine, you look at cancer screening, you look at treatment of blood pressure, high blood pressure. There are so many different opinions as to how to do it. There's controversy in medicine. Medicine doesn't shy away from controversy. Medicine faces controversy. There are different opinions. You have difficulty sometimes in publishing guidelines that everybody can agree with how to manage an illness. The one area of medicine for which there's no controversy is vaccination. There is zero reputable expert in the field of vaccinations that doesn't say that vaccinations are an extremely wonderful and effective way to treat illness, prevent illness. Now, not every vaccine should be given to every person, but the appropriate vaccines should be given. And COVID-19, I cannot think of a more appropriate vaccine than COVID-19 to take this vaccine as soon as you can, because it will save hundreds of thousands of lives. There are very few things we can do in this world to save lives. And in our holy Talmud, it says that even saving one life in the world is if you save the entire world. And here you could save countless lives by your getting vaccinated, by your masking and social distancing. This is part of the plan. These are, in my opinion, religious obligations. There's the rabbi talking, not the doctor. I think these are religious obligations for a person to protect his own health, her own health, and the health of the community, the Jewish community, and the general community. There's no distinction. And every person has an obligation to be kind to other people and to be life-saving to other people and not sit idly by while somebody unfortunately could get sick and hurt because you weren't careful.
Let's take just a step back. We got a question. Our Chief Operating Officer, Noam Gilbert, is fielding some questions that are coming in the chat. And we encourage you, if you have a question, please do put them in the chat. The question is, well, how do you contract COVID-19? Just through the air or through touch? Can you read your newspaper in the morning? Can you touch the mail that comes into your mailbox? Because we've gone through various stages of again, what's been circulating mostly on the internet as to what is and what isn't. And now we're talking to an epidemiologist. So please fill us in.
Sure. So we certainly at this point know that the major route, by far the overwhelming route, is one person transmitting it to another person through the air. There is a potential through touch, very, very low likelihood even in contact with somebody, you're getting it from the air. And people should not be worried about opening up the mail. And a lot of the concerns that we had originally in terms of contact, one still should be careful about washing the hands. If you're in contact with a person who has COVID, you obviously, as healthcare workers or caregivers of any sort, you should be very careful about washing hands. But the typical way that a person in a supermarket is going to get is not because they touched the peanut butter that somebody else touched beforehand and got COVID. So what they are going to get is, if they're not careful about masking and social distancing, and you're in the presence of somebody for a relatively short period of time, 10 or 15 minutes, that could put you at risk for breathing in the COVID that is in the air and coming down with illness. Now, remember that the person who has it may be totally asymptomatic. They feel great, they feel fine, but they can still effectively and very effectively transmit COVID. The biggest places,
go ahead.
Just one last thing. The biggest places where people are going to spread COVID are at eating types of events, weddings, or kiddishes, or at social gatherings where food is served, and people, by definition, are taking off their masks. By definition, they're in close proximity to each other. We all love a good kiddish. We all love to get together with friends and have dinner. However, that's a very dangerous type of activity, what we call a super spreader event. And that's probably the main way that COVID is most efficiently spread when people are in close proximity for a while, when they're eating together without masks on, and especially if it's indoors, and especially if it's in a relatively small group.
Thank you. Can you tell us as to what decisions are made by doctors such as yourself? You talked before about everybody should receive this, but prioritizing who should be top on the list and where do you go from there?
So I think that the government has relied very heavily on the Advisory Committee on Immunization Practices to guide them. And again, guidance is a critical word. It's a guide. It's not an absolute. And Jewish law certainly has a lot to say about who should get vaccines, who should be prioritized. And my personal recommendation would be that the healthcare workers get it first, because if you don't have the healthcare workers available to care for everybody, the system will fall apart. And we're running into tremendous problems with quarantine and isolation because healthcare workers also have personal lives. They're not getting so much COVID in the hospital from their patients. They're protected, but they're also human beings, and they're out there, and the kids go to school, and a nurse is not able to work for us because her kid got COVID in school. But if all of the healthcare workers could get vaccinated as soon as possible, then some of those concerns with staffing would go away. So that would be my first priority, to be able to provide care for the rest of the country, not because they themselves personally are at the highest risk. A 25-year-old nurse, a man or a woman, is going to be at a much lower risk than a 75-year-old person, but they, number one, coming into contact every day, so their likelihood of getting COVID is much higher. And number two, the potential to spread it to patients is much higher. And number three, we can't let them work in the hospital if they get COVID, and we're going to run out of staff. So that's why I would list, and why the advisory committee listed healthcare workers as the first one. Some people said, well, the healthcare workers deserve it. That may be true, but that's not a reason to give them first priority. Now, the one area where I would have done things a little bit differently would be in patients who've had COVID in the past. Now, the official recommendation is that they can get COVID vaccination again. My thought would be that those patients are at somewhat lower risk, obviously, a greatly lower risk of getting COVID right away. And if you're trying to vaccinate the highest likelihood people of getting COVID and preventing them from getting COVID, I would have then gone and given, instead of people who had COVID already, even though they fall into high risk groups, I would have given it to the most highest risk patients, the senior citizens, people above, let's say, the age of 55. Not calling them necessarily anybody senior citizens, but people above the age of 50, 55, 60. And every decade that you go up, you increase the likelihood that these people will have more severe illness. So certainly in the 8th decade of life, the 9th decade of life, it's a higher rate than the 7th decade of life. So you'd have to pick some arbitrary age. And if we started at 85, that's fine. If you started at 75, that's fine. I would go down to as low as 55 across the board and say those people are at higher risk. And if you needed to stagger it, do first the older people, then the next older people, the next older people, and get those people vaccinated as soon as possible, because A, they're the ones most likely to require hospitalization. If we're worried about a pressing overwhelming of the hospital system, so go and prevent it in the people most likely to need hospitalization. A 25-year-old could need hospitalization, but much more likely than not. So you'd want to certainly vaccinate the people that are at the highest risk of getting complications from COVID and needing hospitalization. And then I would have not have chosen various job categories first. I would have done by age as the first and most important thing. And as the next category, I would have considered people with extremely high risk factors, even though their age may not be a high risk factor. It's very hard to quantify that. At what level of elevated BMI, basal metabolic index, would you say that's a higher risk? Is it 25? Is it 30, 35, 40? Every one of those numbers could be supported as a higher risk. At what level of hypertension or what level of diabetes? And it becomes a lot more subjective. So I would have used personally the age criteria and saying anybody eventually above 55 gets vaccinated first. And then we can talk about subgroups of people that are at very high risk. And that's a lot harder to do in a public health overnight type of trying to vaccinate everybody. But hopefully with the increased production and hopefully increased vaccines, we'll hopefully have the AstraZeneca vaccine, Johnson & Johnson's producing a vaccine, other vaccine candidates will come along. Hopefully by the end of the summer, we'll hopefully have enough vaccine to have vaccinated everybody. But it is a difficult logistical rollout.
So another question is coming in from the audience is, why are there two vaccines, A, and then B, how long after getting the second vaccine can you attempt to live life as normal?
So I think the first question is a great question. Second question is as well. But the first question is why the two vaccines? It's God's gift to us. If we only had one company giving us a vaccine, so then everybody said, well, how do we know that it's right? How do we know it's really as good as they say? But here you had two totally unrelated companies. Moderna doesn't speak to Pfizer. They're two totally unrelated companies. They did totally unrelated studies. They have a very similar but not identical product, same technology, but not identical products. They did the same exact study simultaneously and got the exact same results. You could not have asked for better scientific proof than having two simultaneous studies done independently, giving you the wonderful results in terms of efficacy and safety that we got. So that's phenomenal.
Yeah, beyond the two different companies, I should have been more specific. Two doses. Why you have to get inoculated twice as opposed to only once?
So one inoculation of either the Pfizer or Moderna vaccine will give you some protection, but you'll get a much more fuller protection. You get a boosted level of immunity with the second dose. And it is strongly recommended that everybody get a second dose of those two vaccines eventually. Whether that is the only way to do it, whether in England, for example, they're giving one dose to everybody that they possibly can. I personally think the way that we're doing in the United States is better. Let's get people immune. Let's be able to eventually get to the point where we know that these people will not get or transmit virus because they've been vaccinated. And that is the goal. We don't know that 1,000% yet. And we need a little bit more time to know that once you've gotten both vaccines, thank God you're probably not going to get sick. But the $1 million question remaining is, can you still transmit virus to somebody else, even though you're vaccinated?
What about well, let's get to the second question about life as normal. When does that happen?
So that's going to take a little bit more time. I think for people that are vaccinated, their personal lives will be a little bit better in terms of their personal socializing. Let's say grandparents are vaccinated and their kids are, let's say, vaccinated or had COVID. So there may be an opportunity for them to freely eat together, be together, where in the past they would have needed to wear a mask and social distance. But going out into society, since we don't know yet the answer to if you're vaccinated, are you incapable of transmitting? So for the present time being, when somebody comes to temple, somebody comes to the supermarket, somebody goes to work, they still need to remain masked and social distance. I'm blessed that I've gotten both doses of the vaccine. I'm alone in an office right now. That's why I'm not wearing a mask. As soon as I go out, I wear a mask and I social distance. In shul and temple, I wear a mask and social distance. Throughout the hospital, we all wear masks and social distance, even though most of us are vaccinated at this point in time. And I think once we get most of the country, and that's why it's so important that everybody get vaccinated, once we see the decline in COVID cases, once we see that the epidemic is under control, then hopefully, maybe in the summer, maybe before then, maybe after then, who knows? Only God knows. Maybe then we can stop masking and social distancing and hope that this pandemic has been brought to its knees. It certainly has brought us to our knees till now.
And thank you. But what about the mutations? We have the UK mutation. We have the South Africa mutation. So how does this vaccine relate to how effective is this vaccine against the mutations? A, and B, is it possible that this virus can continue to mutate where the vaccines won't be effective?
So those are also very good questions. They have a very smart audience. So the vaccine, I keep on saying vaccine, the virus can consistently mutate. Viruses do that. RNA viruses tend to do it more than DNA viruses. And this particular COVID-19 does it a little bit less than other viruses that it's like or similar to, which is good. But it's been mutating from the very start. And we're not 100% sure exactly what that means from a practical point of view. Some of the new mutations are felt to be more contagious, but thank God none of them are more virulent, meaning that they don't cause more severe disease. And to the best of our knowledge at this point in time, and there are some preliminary data that were just published last week, the vaccine should work against these new strains of virus. And I can get very technical and explain why that might be true. But suffice to say, at this point in time, based upon everything that we know, these vaccines will work against the UK strain, the South African strain, and other strains that are constantly coming up. And I hope that remains true. We'll definitively be able to say it when we see that cases go down in highly vaccinated populations.
Yeah, so we talked about getting the shot and getting together with family again. So that's an issue of transmission. Does the vaccine prevent transmission?
So we don't know that. As I said, there is a concern that a person who's vaccinated might not get sick. But let's say, for example, I'm vaccinated now, and I go into a patient's room with COVID-19, and I don't wear my mask. I come out, I'm fine. I don't get sick. How do we know that I'm not silently, asymptomatically carrying that? Many people with COVID carry it silently. Maybe the vaccine just prevents me from getting sick, which is wonderful, but it doesn't prevent me from potentially spreading it. I have an asymptomatic infection. We don't know if that's true. We don't know that it's not true. And that's why we still need at this point in time, until we have evidence that that's true, and it's true 100% of the time, that we wouldn't need to mask and socially distance. We also have to remember that it's 95% effective, which means that it's 5% not effective. And therefore, one needs to be very, very careful still in that small percentage of situations. Hopefully, even if you do get sick, you'll get milder illness, and that's what the studies have shown.
And what percentage of the country, let's say here in the United States, needs to receive the vaccine in order to achieve herd immunity? How long do you foresee that taking?
So it's going to take a while. We're estimating that you probably need to vaccinate up to 90% of the population. Even more than that would be better. Again, the only people that shouldn't be getting this vaccine are people that had a severe allergic reaction to the first dose of the vaccine, or have had very, very severe anaphylactic reactions to other vaccines, or to what we call injectable. You're getting something intravenously or intramuscularly, and you had an anaphylactic reaction, which means that you basically die, and they have to bring you back with CPR. They were pounding on your chest and breathing for you, or doing heroic measures to make sure that you survived whatever it was that you were allergic to. But people who have shellfish allergies, peanut allergies, they can take this vaccine.
Yeah.
It's only very specific that you had a reaction to an injectable, either medication or vaccine in the past. And those people can still be potentially vaccinated, but they should be done it under the most careful conditions, and a decision should be made by the infectious disease doctors, the immunologists, and other staff, whether it's worthwhile. We've had some staff that were at very, very high risk of getting COVID, who had severe allergic reactions in the past, and we vaccinated them with no problems.
So we're running out of time, and I got two more questions from the audience I'm going to throw at you. Are people with different blood types affected differently by the vaccine? That's number one.
So let me answer one at a time.
What in the vaccine?
Let me answer one at a time, so
Okay.
I don't forget. So I think that there are some suggestions that people with certain blood types, such as A, are more likely statistically to have more severe disease, and maybe with blood type O, they're less likely. From a practical point of view, ignore it. If you have O, don't walk around without a mask. If you have A, don't hide in a closet somewhere. So it has no practical significance. You have the blood type that God gave you, and hopefully it will be a good blood type for you, but don't worry about it. Don't even think twice about it.
Okay. Then the next question is, how can we convince 90% of the population to get vaccinated?
So I would invite them to come in, unfortunately, to my hospital, which you can't do right now, and look at the sick, dying patients that we still have. Look at patients on a respirator. Look at patients who can't catch their breath. Look at older people that are missing their grandchildren and not hugging them. Look at businesses that have been closed. Look at the economic disaster that we're facing because businesses can't open because of, unfortunately, COVID surges. And do it as a kindness. We have an overriding principle in Jewish law: love your fellow man like you love yourself. Nobody wants to get sick. Nobody wants to see somebody else sick. By taking this vaccine, you're doing not only yourself a favor, but you're doing every single other person in the world a favor. It's such a small risk that you're taking with such unbelievably great rewards of saving life. It is a mitzvah par excellence. It is a wonderful way, a good deed that you can do to help out all of humanity. What an opportunity God has given us. And I hope everybody takes this opportunity, and we can all count it on our ledger this coming Yom Kippur. When we ask Hashem, we ask God for atonement, we can say, God, help me because I helped every single other person in this world.
Normally, I thank you so much for that response, but normally I ask our guests for a last word. You've probably given me the best last word possible, but usually it's after my thank you to our sponsor, which would be now. So think about another potential last word after I finish reading the message from our sponsor. And this episode indeed has been sponsored by the Free Synagogue of Flushing, serving the Reformed Jewish community in Queens, New York for over a century. Visit freesynagogueflushing.org to learn about the wide array of programming in the beautiful sanctuary, social hall, and meditation garden available for rent. Visit freesynagogueflushing.org to learn about their Shabbat and holiday services, their weekly Sunday school. Once again, visit freesynagogueflushing.org. Our thanks to their president, Ed Schauder, who's a member of our board of directors, their cantor and executive director, Alan Brava, to Rabbi Jeffrey Gale, the rabbi of the synagogue, to my three Gs, Noam Gilbord, our chief operating officer, to Rebecca Grossman, and to Jennifer Glick, who help us produce these Community Relation Corner episodes. And just one additional thanks this segment on this episode to Brad Korn, who is one of the executives within Mount Sinai in Manhattan. And I'm sure he would appreciate having had Dr. Glatt from Mount Sinai in South Nassau on this program. So thank you, Brad, as a very dedicated board member. Now I'm going to turn it over to Dr. Glatt for a final word before we say shalom. Dr. Glatt?
So thank you again for having me. I appreciate it very much, the opportunity to try and help educate people. We do need everybody to get vaccinated. And I always tell people that we have choices that we have to make in life. A person can decide to be selfish. A person can decide to be extremely magnanimous. It's a choice. God has given us what we call bechira chavshi. We can have free will to be kind, to be nice, or unfortunately the opposite. And I would urge, beg, implore everybody to be a kind person. And if you have doubts about this vaccine, that's okay. I hope I've been able to eliminate most, if not all, of your doubts. But if you have doubts, but you know that all the experts in the world, the leading doctors, the leading rabbis, all strongly recommend this. Put your trust in those experts. Put your faith and trust in God. Know that you're doing what you're supposed to be doing by getting vaccinated. And then the world will be a better place for all of us to live in. A safer, healthier, and happier place. So thank you again very much for having me. It's been an honor to be on your show.
Thank you very, very much, Dr. Aaron Glatt. It's really been a pleasure having you here. Your presentation was just extraordinarily informative for us. And I just underscore your message about how important it is that we maintain social distance, that we wear masks, that we wash our hands, we do everything possible and take the vaccine when it's available, do everything possible to just destroy this virus rather than having the virus destroy us. My thanks to our wonderful viewing audience, those who viewed us live and those who will view us once we're online on Facebook, on YouTube, etc. So my thanks to everyone for participating. Let me wish you a wonderful week, end of week, a Shabbat Shalom, a good Shabbos to everyone. Shalom, shalom, be well, take care.